one of the things that we saw with drug-resistant tuberculosis, as with AIDS, is clinical nihilism. So what's clinical nihilism? Clinical nihilism is when you say, well, it's really too difficult to treat this disease in this setting, right? So AIDS across the continent of Africa, MDR-TB, wherever it was a hassle, meaning again, in settings with very restricted resources, that's clinical nihilism. I think now, and this is one of the benefits of having a social medicine approach, so you can step back and see where clinical nihilism is rearing its head, right? It would be very difficult to say, for example, in the afflicted city of New York at the height of the epidemic, well, this is our standard of care for people from Manhattan. We have a different standard of care for people from the Bronx, right? So clinical nihilism has a hard time playing itself out in settings of affluence. But what about containment nihilism? That is, not that it's too difficult to treat COVID, but it's too difficult to prevent its spread, to do contact tracing, to understand how to slow down transmission when there's already so much of it going on in the community, to do our jobs and provide good clinical care. That is containment nihilism.